Welcome to AETCM, the emergency medicine channel. So today I'll be discussing about the topic migraine. So it's one of the most common presentations in ER, and the patient presents with the complaints of headache. So let's just discuss about the symptom headache. So what are the major causes of headache? So we can divide it into based on primary or secondary causes of headache. So primary causes are more like a benign cause of headache. So the most common ones which we see is tension headache. So tension headache is basically they will complain of a band like sensation around the head. So that is the most primary complaint they will be talking about. And then the other one is migraine, which we will discuss in detail. And then we have the cluster headache. So cluster headache is basically unilateral headache, and that headache will be associated with autonomic features as well. So the headache, as when you describe the headache, it usually presents as a cluster. In the name itself it said cluster. So it presents at the same time every day, and it presents it is present for the some weeks to days to weeks, and then it will disappear, and then again it will come back in cluster, and again the patient will present with similar symptoms, and it will be associated with autonomic features. So autonomic features in the sense like the patient will be complaining of unilateral eye lacrimation or redness, or patient will have like rhinorrhea, like that symptoms the patients will be complaining of. And then we have the trigeminal neuralgia. So trigeminal neuralgia basically it is due to the compression of the trigeminal nerve root. So it can be due to multiple causes as well, due to some aberrant artery compressing on it, or due to some secondary causes like any other mass lesions compressing on it, or any intracranial space occupying lesions compressing on the trigeminal nerve roots. So those patients will present with a classical unilateral lancinating facial pain. So the facial pain distribution will mostly be in the area where the trigeminal nerve supplies. So it can be involving either the first, second or third branch. Mostly in the second and third nerve distribution is where the patient will complain of pain. So the trigger of the trigeminal nerve will usually be either a touch, like a light touch, or some wind, or like that, or while chewing and all, the patients will complain of a unilateral lancinating facial pain over one side only. Okay, so that is how the trigeminal neuralgia is. And then coming to medication overuse headache. So that is mainly due to the overuse of the opioids or other analgesics, and then patient will have rebound headaches occurring. So that also we have to then taper them down on the analgesics. Then there are other paroxysmal headaches like benign paroxysmal headaches, and other kind of headaches are also there. Then we also have secondary causes for the headache, which is more significant, and we should not fail to miss such headache presentations in ER. So coming to the secondary causes, you have to rule out other structural causes, like structural causes in the sense like if there is any intracranial space occupying lesions, or is there any intracranial bleed, or is there any stroke. So any other conditions like infective causes also we will have to rule out, like infective causes in the sense like meningoencephalitis, meningitis encephalitis, those causes also we will have to rule out. Then inflammatory causes will be like the vasculitis causes. The most common is the temporal arteritis. So the temporal arteritis can also present as a unilateral headache over the temporal region mainly, and there will be tenderness. Due to the inflammation of the temporal artery, the patient has the headache. So there will be tenderness around that region, and it's usually seen in more than 50 years of age. And also they will have associated complaints like jaw claudication. While chewing food, they will be complaining of pain or fatigueness or while chewing the food, and also they will have maybe some visual complaints as well, like transient loss of vision, as in amaurosis fugax. So that is that like TIA presentation. So those patients can also have such a presentation as well. So that also needs to be differentiated. And then other vascular causes like as I said now, the intracranial bleed or the stroke, the cerebrovascular accidents, all of those things can also present as a headache. Then other causes like other benign causes like sinusitis will also have facial pain. They will have sinus tenderness as well. Or in other causes, one common causes in older age group which we see is glaucoma. So glaucoma patients can also present with a headache, mostly a periorbital or a retroorbital pain they will be complaining of, and they will have associated conjunctival injection or redness of the conjunctiva and other associated features of glaucoma will also be present, and IOP will be raised obviously. And coming to the red flags, so how do you differentiate which one is which? Is it a primary cause for the headache or is it a secondary cause for the headache? So to differentiate which is more important or which requires imaging, to be more specific, which requires neuroimaging like CT or MRI, which one requires which? So that we can make based on checking for the red flags in the patient. So when the patient presents to ER, we will have to see for the red flags and rule out all the secondary causes for the headache. So coming to the red flags, so we have a mnemonic here. So we have a mnemonic here, it is called as SNOOP. SNOOP for SN, double O and 4 P's. Okay, so it's SNOOP 4. So SNOOP 4 will say it as systemic symptoms. S is for systemic symptoms, as in like fever, chills, or any patient presents with weight loss, like that symptoms and all will be more ominous of a sign of infection or maybe an underlying malignancy as well. So that also we'll have to see. If a patient is having any underlying malignancy and the patient presents with headache, then that is also significant. We have to do a neuroimaging. And infection wise also we'll have to see if there is any meningoencephalitis features, and also if the patient is having any underlying HIV is there, then that also is an indication. If the patient has a severe headache, then that also requires a neuroimaging because the patient is immunocompromised. And then other thing is the N is neurological symptoms or deficits. So the patients will complain of unilateral weakness, or a patient has other focal neurological deficits as in ataxia, dysarthria, facial palsies, or other cranial nerve palsies, or the patient has sensory symptoms, hemisensory loss. So all of those neurological deficits we have to see, and if it is there, we have to suspect any stroke or any space occupying lesions or any encephalitis. So those things we'll have to rule out. And O is for old age. So more than 50 years is where it gets into more of a red flag kind of situation. So the patient is having a first time headache in the older age, then we'll have to do a neuroimaging ideally. And that we have to rule out other causes like temporal arteritis, glaucoma, or any space occupying lesions or mass lesions we'll have to rule out. And then onset wise, we have the thunderclap onset or the acute hyperacute onset. So with a severe intensity of headache, then we'll have to rule out SAH, which is the one of the most common. The patient presents with a thunderclap kind of headache, the worst headache and the first headache and the worst headache in his life. So that thing also we have to screen. Then the P is for papilledema and positional changes. So papilledema implies raised ICP. Positional variations of the headache. So the patient says the headache gets aggravated on positional variations, like patient bends or lifts heavy weight or does any exertion, as in if the patient has cuffs or any exertion is increasing the headache, then we'll have to suspect raised intracranial pressure. Okay, and the other one is the progressive or pattern change. So last P will be a progression of the symptoms. The symptom is continuously progressing, not relieving with any kind of treatment or medications, and then or the patient suddenly the patient has a pattern change or a frequency change. So the first one, progression, is basically it is persisting, and then we'll have to rule out other secondary causes. But if there is a pattern change, in the sense like if a migraine patient presents with a like usually a unilateral kind of headache, and always on one side, and suddenly the frequency had started to increase and the severity has increased than previous, and the position also or the location of headache has also changed, or it has become bilateral, like that kind of situations, we'll have to do a neuroimaging to rule out other secondary causes. So that is basically the SNOOP 4. So it is SN, double O and 4 P's. So these are the things you need to rule out in ER. Okay, and coming to migraine proper. So migraine, so we'll approach it based on our old mnemonic, Socrates mnemonic. So the history, how will we take the history to see if it is really a migraine? So it's basically a clinical diagnosis. So the proper history taking is important in this situation. So the site will usually be unilateral. So the patient will complain of a unilateral headache. So onset will be usually acute onset with it will be an acute onset. C, what is the characteristic of the pain? Pain will be usually throbbing type of pain. Throbbing type of pain. What about R? R is the radiation of pain. That usually doesn't, it's not usually there. And then coming to the associated symptoms. So the associated symptoms, there are multiple associated symptoms. There can be nausea, there can be vomiting, or there can be any auras that we'll discuss in a bit. Aura presentations can also be there. Then other presentations also of migraine also will be presenting the associated symptoms which we see commonly in migraine. Then coming to T. T is duration. Usually it lasts for 1 to 2 days. And exacerbating or relieving factors. So usually it gets exacerbated or aggravated in certain situations, like there are certain triggers that also we'll be discussing. So certain triggers are there which will exacerbate the condition or begin the symptoms starts to occur once the trigger patient is exposed to that trigger. So that aggravating factors also we'll have to rule out. And then patient usually will have increased sensitivity to light, sound, smell, like photophobia, phonophobia, like that symptoms also the patient can say. Those things will be aggravating the symptoms. And then relieving factors, usually it gets relieved by the usual medications which we will discuss, and those medications usually will the patient will get relieved of the symptoms, and will get relieved in when the patient sleeps in a dark silent room, it gets relieved. So those kind of symptoms also we have to see. And then S, and yeah, so we have discussed about the exacerbating or the relieving factors. Okay, and then further we will discuss about the causes of migraine. So basically, so we have the migraine. How will you describe migraine? So migraine is a unilateral throbbing severe intensity. Yeah, S is for severe intensity. So that also the severity of the headache will be severe. It usually will be moderate to severe intensity of headache. So those things here is a severe unilateral throbbing kind of headache is basically migraine, and it will have associated nausea, vomiting or auras, and they will be aggravated by photophobia, phonophobia, other features or triggers will be there in with the headache as well. And then coming to the causes, that can be inherited. It's usually inherited, and it has a familial origin of that headache. So the genetic reasons are mainly the cause for migraine. So there are certain genes which get modified, and that is responsible for migraine. So there is KCNK18 and CSNK1D genes, and familial hemiplegic migraine, there are certain genes, especially SCNA1, then CACNA1A and ATP1AZ. So these genes are now responsible for familial hemiplegic migraine. Then there are certain triggers. So the triggers we'll just discuss. So what are the most common triggers? The most common one is stress. So stress is the most common one, and other factors also are there. Weather variations can also cause weather variations, or decreased sleep, skipping meals, the patient skips meals, or the patient consumes other certain food items. Certain food items are particularly notorious for causing migraine. For it's different for different patients mostly. So any tyramine compounds or any chocolates or like that compounds, usually there are certain food groups which are sensitive for each and every person. So that trigger is there. Then alcohols, usually wine can trigger, smoking can trigger, or light, sound, smell, as we said earlier, light, sound, smell, all those things, and you can trigger migraine. Then there can be hormonal fluctuations. So any estrogen withdrawal situations can also cause migraine. So it is usually seen in the during the menstrual periods or the pre-menstrual periods, or during the ovulation periods, during pregnancy. and postpartum periods and all those times it also can get aggravated. There are certain metabolic or biochemical factors as well causing migraine. There can be either mitochondrial dysfunction or some ion channel dysfunction like sodium, potassium, calcium channels dysfunction can also cause, or there can be serotonin dysregulation as well. So these also can lead to migraine. Then there are certain autoimmune causes as part of some autoimmune disorders like SLE and all can present with migraine. Pathophysiology is a bit complicated pathophysiology, but just to simply just to say give you a brief idea about the pathophysiology. I'll just have shown here a flow chart. So with the trigger, when the trigger or the sensitizer event occurs, then there is a thing called as cortical spreading depression. So that is the main pathophysiology. There is a cortical spreading depression. So the depolarization wave spreads across the cortex. So it's a cortical spreading depression of Leo. Cortical spreading depression of Leo. So it causes neuronal or glial depolarization followed by inhibition, and that is mainly responsible for the aura. So wherever the waves or the depolarization waves go, there are the patients will be experiencing the aura symptoms. And then there is the trigeminal vascular system activation, because the trigeminal sensory afferents, the trigeminal nerve sensory afferents are activated by this depolarization wave, and this causes release of the vasoactive neuropeptides, as in those which like certain inflammatory peptides like CGRP, calcitonin gene related peptide, nitric oxide, substance P, neurokinin A, all of those peptides are involved, and this causes neurogenic inflammation and vasodilatation. Subsequently, it causes vasodilatation of the cranial blood vessels, and so it causes vasodilatation of the cranial blood vessels, and this causes sensitization of the pain pathways as well. So there is vasodilatation as well as the sensitization of the pain pathways. Central and peripheral pain pathways are sensitized, and the patient will have more pain, headache, and pain perception occurs. So symptoms mostly it can be divided into common migraine or classical migraine. Common migraine is basically just headache, migraine headache with vomiting. So patient will have migraine headache with vomiting in common migraine, whereas in classical migraine it will present with aura symptoms as well. So the aura symptoms usually it can either be visual auras, like the patient can complain of a scotoma or a blackening of vision in a field of his vision, and that can be transient, and it lasts around less than 1 hour, and or a patient can also see some kind of like a shimmering or a silvery zigzag lines. So zigzag lines he can visualize, or so basically that's scotoma or the silver zigzag lines. These are the most common visual auras the patient can present with, or the patient can have other sensory auras. Patient can have paresthesias or numbness, which is changing every minute from one part of the body to the other, or the patient can have motor auras, weakness, can have transient weakness, or can have other auditory or auras as well. And the phases of migraine is basically it has initially a prodromal phase. So the patient will have a depressed mood, or a patient will be agitated, or they have mild altered altered state of mind, and they will be more anxious, and by when the aura comes, they will have these aura symptoms, and followed by that there will be an acute attack. So the acute attack will present with that headache and vomiting episodes, and then there will be the resolution phase when all the symptoms will disappear, and there will be a post-traumal phase again with a low mood and fatigability will be present, and then there will be interictal phase, which is a normal phase in between the migraine episodes. So this doesn't occur in this order, it just when you say about the phases, usually it happens like this, but in reality it doesn't occur as such. It can either present as an acute attack, or it can be an aura followed by an attack, or it can be only an aura without any other symptoms of headache, anything like that, or like that also the symptoms can present. So the types of migraine is also important, so that also we need to know. So the types of migraine, this is important. Coming to the types, we have the vestibular type. So there are many multiple types of migraine. So here one vestibular type usually has vestibular symptoms along with the migrainous headache. So the patient will complain of what do you say, like will complain of vertigo, tinnitus, hearing impairment. So that vestibular symptoms will be present along with the migrainous headache. Or the patient can have ophthalmoplegic migraine, in which the symptoms of ophthalmoplegia or diplopia will be present, and it usually affects the third cranial nerve and less likely the 4 and 6 cranial nerve. So third cranial nerve usually gets affected along with that headache. So patient might complain of a transient diplopia as well. And then there is a retinal migraine, which is the scotoma, which we have said earlier, which is the visual aura. So this scotoma or the transient loss of vision will be present, and it will recover by within less than 1 hour. So that kind of retinal or ocular migraine is called as. Then there is hemiplegic migraine, in which there will be weakness, unilateral weakness will be present. And then there can be basilar migraine. Basilar migraine is basically the patient presents with a brainstem symptoms, like brainstem stroke symptoms. So they will have some dysarthria, diplopia, ataxia, or any vestibular symptoms like vertigo, tinnitus, hearing impairment, then ataxia. Like those symptoms will be present. It's also called as migraine with brainstem aura. Okay, so that is the basilar migraine. Then migrainous infarction can occur. What is that? So migrainous infarction is basically the patient will be having a migraine headache, and due to the severity we might image the patient as well. So neuroimaging will show an infarction or an infarct in the MRI. So that is called as migrainous infarction. So that is another complication of migraine. And then there can also be migraine aura triggered seizures as well. So that is another complication of migraine. Then there can be other presentations like abdominal migraine, especially in children it's seen. Abdominal migraine, the patient complains of a central or a non-localized abdominal pain, and other investigations will be normal. So the patient might or might not have associated headache as well. So it's a bit complicated diagnosis, but that it can also be a presentation in children. Then there can be menstrual migraine, as we discussed, due to the hormonal fluctuations during the menstruation or during the ovulation period. There will be, due to the estrogen withdrawal, there will be the migraine episodes. So that is the menstrual migraine. Then there is status migrainosus. Status migrainosus, basically the migraine episode lasts for more than 72 hours. That is status migrainosus. Management wise, we have to basically avoid the triggers. So the triggers which we had discussed, so those precipitating factors we will have to avoid. And then the second one, based on if it is mild or severe migraine. Mild migraine we can manage it with paracetamol or NSAIDs, whereas if it's a severe migraine, we will have to, with NSAIDs we have to add other treatments as well. We have one such treatment is metoclopramide. Metoclopramide is basically dopamine receptor antagonist. So the dopamine receptor antagonist, it has action on the CTZ, which is the chemoreceptor trigger zone. So that site of action will also inhibit the vomiting episodes of migraine, as well as due to the dopamine receptor antagonist activity, it will also inhibit the pain pathways. So it is a preferred drug for a patient who presents, a migraine patient who presents with headache with vomiting. It inhibits both the vomiting as well as the headache episode. So that is about metoclopramide. Then there is 5-hydroxytryptamine agonist, which is serotonin agonist. And also opioids can be used, but opioids, the problem is that chronic use of opioids will cause dependence. So other preventive therapies and all won't usually work, and patient will be coming to ER recurrently to get the opioids. So that should be usually avoided, and other kind of treatments we will have to focus on. So the 5-hydroxytryptamine agonist, they usually bind to the 5-hydroxytryptamine 1B or 1D receptor. So what happens, what is the mechanism of action? It inhibits the vasoactive peptides which we discussed earlier, the nitric oxide, neurokinins, the CGRPs, all those kind of active peptides are inhibited. And then this can also increase the vasoconstriction, because the pathophysiology was vasodilatation causing all the pain. So it will cause vasoconstriction, and also it will block the pain pathways. Then the precautions we have to take while giving triptans is, due to the vasoconstriction it causes, the patient has an angina or MI, or we can cause more of a coronary vasoconstrictions, or if the patient has a CVA chance or risk factor for CVA, then it can cause more vasoconstriction and lead to CVA, or if a peripheral vascular disease also, it can worsen the condition. So that also, so the triptan groups we have to use it carefully, and usually in younger or middle aged group we can usually use this. And the triptans which we commonly use are sumatriptan, which is the sumatriptan. So sumatriptan, the dose is 100 mg, 50 to 100 mg, and maximum we can give 200 mg per day. And usually we can repeat one more dose 2 hours apart. And the one which is available in our hospital is risatriptan. We have a oral disintegrating strip, so we'll just keep it in the mouth and it will disintegrate in the mouth itself. So it is the dose is usually 5 mg. That will usually give us SOS. Whenever there is an acute worsening, then we can take the strip. And then there is zolmitriptan as well, which is also, both of sumatriptan and zolmitriptan is available as nasal sprays, and dose nasal spray for zolmitriptan is 5 mg, whereas for sumatriptan is 10 mg. We give in one nostril. And in ergotamine is another 5-HT agonist, serotonin agonist. So it can be given as 2 mg sublingual route, and we can repeat it every half hourly. Maximum we can give us 3 doses we can repeat per day, or we can repeat maximum of 5 doses per week. So that is the maximum dosing we can give with ergotamines. If nasal sprays are available, then there is a 0.5 mg. When you give one spray, 0.5 mg will be delivered, and we can repeat every 15 minutes. Then as tablets, our IV route is dihydroergotamine mesylate. So dihydroergotamine mesylate we can give as IV route, which is 0.5 to 1 mg IV, or 1 to 2 mg sub Q or IM we can give. Tablets ergotamine is 1 to 2 mg we can give every 30 minutes. So most commonly we have this ergotamine caffeine combinations. So these can also help with help in the acute attack of migraine. Then menstrual migraines we can add on treatment. We can add on OCP pills, like with progestins and estrogens combination. OCP pills we can add, and we have to give it for extended cycles. Or we have to give ethinyl estradiol, which is estrogen alone. We can give 10 microgram ethinyl estradiol we can give. And then sumatriptans can also be given for menstrual migraine, or ergotamines can also be given, and magnesium sulfate also can be given. So other therapies which we can use as an adjuvant therapy is oxygen. Oxygen, what it does is usually causes vasoconstriction. So in that way also it can help. And magnesium sulfate can also be used as adjuvant. So that dose is usually 1 to 2 gram IV we can give, and we should also make sure to switch off the light while in ER as well. Okay, and other treatments which are the newer treatment modalities. Newer treatment modalities are the CGRP antagonist. So CGRP is the vasoactive peptide which we discussed earlier. So that we can give as a CGRP antagonist, which is rimigepant. Rimigepant is 75 mg as a single dose we can give. So what is the use of this agent? It's actually used whenever the other conventional treatment fails, and the patient has some underlying CAD background or any CAD risk factors are present. We can give a safer drug, which is the CGRP antagonist, or we can also give the selective serotonin 1F receptor agonist. We can give the serotonin another selective serotonin receptor agonist, which is lasmiditan, which is 50 to 100 mg, and we give one dose in 24 hours. This is also safe for CAD in CAD patients. And then coming to the prophylaxis. So who all will give prophylaxis? That question is important. So we should know who all we can start on prophylaxis. If the patient is having more than 2 headaches in a month with the disability more than 3 days per month, then the patient is has to be started on prophylaxis. Or if the patient is having prolonged headache more than 2 days with disability, then also it's an indication. Or if the patient has other neurological complications as well, other neurological symptoms interfering with daily activities, then that also we can start prophylaxis. So to easily to remember the prophylaxis, we can I have a mnemonic here. It is ABCs of migraine. So we can give ABCs of migraine. A is for anticonvulsants, antidepressants, antipsychotics, like those drugs. So antidepressant, antipsychotics we can give is amitriptyline 10 mg HS we can start and then increase dose, or fluoxetine 20 mg OD we can start. And anticonvulsants, topiramate is given as 50 mg BD, and lamotrigine as 25 to 100 mg per day we can give, or valproate as 250 mg BD. So based on the patient profile, what the other associated complaints of the patient, so what other issues the patient has, like in case the patient has some kind of a stressor, or patient has some kind of a depression associated with that migraine, then we can give antidepressants or antipsychotics. Anticonvulsants are given if the patient has a background of epilepsy. So those kind of treatment tailoring we can do. And then beta blockers we can give to patients with hypertension, or the patients who has background of CAD and less than 50 years and all, we can safely give beta blockers. So in anxiety patients also we can give beta blockers. So what we usually give is propranolol, we can give as 10 to 20 mg BD, that is the starting dose. Then we can give CCBs, calcium channel blockers. We can give, C is for calcium channel blockers. Calcium channel blockers we can give flunarizine. Flunarizine is apart from it can also be used for more than 50 years of age group and patients with hypertension or CAD background, we can give flunarizine. But the other effect with flunarizine is that it can cause more sleepiness. So if the patient has reduced sleep, insomnia also, then flunarizine is a better choice. So that you can give around 5 to 10 mg HS we can give. Verapamil also we can give 80 to 480 mg per day. Then magnesium we usually give 400 mg per day. And other preventive therapies we can do is we can give vitamins, multiple vitamins we can give, which is B2, B12, D and E. So these vitamins are also will help to prevent the migraine attacks. Then we can, newer treatment options are the Botox or the botulinum toxin. Botulinum toxin injections we can give the scalp and temple area, or the trigger sites. So the trigger sites we can give the botulinum toxin injection, and we usually give that when the patient does not respond to the conventional treatment, or does not respond to at least 3 conventional drugs. So those patients we can give botulinum toxin treatment. Then there is newer preventive therapies, which is the CRP antagonist, the CGRP, the calcitonin gene related peptide antagonists, which are the monoclonal antibodies, like erenumab or fremenizumab can be given. And other modalities of treatment can also be tried, like transcranial magnetic stimulator, or we can use vagal nerve stimulation techniques. So basically these are the preventive therapies which we have discussed now. So in whole, we have to know when a patient presents to ER, we have to know how to differentiate if the patient is having a primary headache or a secondary headache. Is there any red flags, or is there any symptoms or signs which suggest that a patient needs neuroimaging? So the red flags of headache, the SNOOP4 we need to identify and do the neuroimaging accordingly. And migraine, as we said, is a unilateral throbbing severe kind of headache, and we have discussed about the symptoms. The patient can present with the auras and the other types of migraine, and the management strategies we can use in the acute attack as well as for preventive therapy. Hope you have understood from this session. Thank you.